Good morning. Thank you very much for being here this morning. I really appreciate the invitation to join you all. I'm going to talk a little bit about the Precision Medicine Initiative Cohort program. There's a lot of pieces of the Precision Medicine Initiative which I'm not going to talk about. And there's a lot of parts of precision medicine that are much bigger than the Precision Medicine Initiative, which I'm also not going to talk about. So I'm going to talk specifically about the Cohort program. When we first started planning for the Precision Medicine Initiative and started talking about building a large national cohort, there were people, particularly in higher levels in the Department of Health and Human Services and in the White House, who were concerned about using the word cohort. But we started using the word cohort, and it has stuck. The word cohort means a group with a shared experience. And in fact, what we're trying to build is a very large group with a set of shared experiences, not unlike some of the groups that have gathered here today. So what we're going to try to do is build a cohort of 1 million or more Americans who agree to participate in research over an extended period of time. So I'm going to tell you a little bit about that this morning. So one important feature of this initiative for the National Institutes of Health is that we are doing things in a non-traditional way. So NIH is the biggest funder of biomedical research in the world. We tend to do things in a very typical way, which is we put out notices of research areas that we're interested in. People take many, many months to think deep thoughts. They send us their very best thoughts. Then we take many, many months to think deep thoughts about their deep thoughts. And then we finally make an award. And we're moving in a much faster pace in this particular initiative. So the Cohort program aims to be the largest longitudinal study ever in the United States. We are setting this up in lightning time. We like to, among the staff who are working on this at NIH and our collaborators and initial awardees, we like to talk about doing things in PMI time, which is, I think, an order of magnitude faster than normal time. And we are doing things in atypical ways in having the prospective participants or participants being partners with us at the get-go. So that is very familiar to all of you in this room, but not so familiar to the way that we typically do things in biomedical research, where scientists have a great idea, they design their experiments, and then they go out and ask people to participate in it. We're flipping that over in much the same ways that you guys have flipped things over, in that the participants are going to be at the table with us designing as we go. So what that means is that each scientific question we want to ask has to meet two standards. One, it has to be kick-ass science, and it has to be stuff that the participants are interested in seeing go forward. So anything that we might do that might threaten the trust, confidence, and partnership that we have with participants would be a non-starter. The other thing is that especially because the president is so engaged in this particular initiative and because it is so audacious, there's a lot of attention to this particular program. And so that means that we're under the spotlight, and that means that we get to show off, but it also means that we can't screw up. So there's a lot of attention to being very, very careful at every step. So these are some of the scientific opportunities that having a cohort of 1 million or more people would allow you to address. I'm not going to walk through them. These are scientific questions and areas of exploration that are familiar to you and are going to be talked about some during the course of the day. I think many here have focused mostly on the genetic contributors to health and disease. We're trying in the Cohort program to integrate other aspects as well, so integrating environmental, risk factors, behavioral, sociological, and others. Once this cohort is established, one of the things that we hope it will enable is that people will be able to launch secondary studies on top of this platform. So if you wanted to have a research study that involved 10,000 people who wore pink socks, you could look through the PMI cohort and find people and invite them to participate in your sub-study. That's particularly attractive to all of the institutes and centers at NIH. So we're made up of 27 institutes and centers, most of them focused on specific diseases or body parts. And so over time, we hope that those institutes and centers will make investments in research using this cohort. So the core values for the cohort program are that participation will be open to anyone who is interested. That poses some challenges for us, which I'll talk a little bit about. We want the cohort to reflect the rich diversity of the United States. If you look historically at who has participated in biomedical research, there is an absence of underserved and underrepresented minorities in research and as researchers. Participants, as I mentioned, are partners at all phases. Our participants will have access to study information. That's also causing some people to get anxious. You guys are familiar with this because that's sort of what you're based on, but it's not necessarily the case for most of the research that we support at NIH, and so it's a little challenging and causing some policy angst at the present time, but we're going to work through it. We want the data to be available readily, so this is not going to be a project where we collect a bunch of data and then maybe at some point in the future you might be able to get access to it, but in real time providing data access. While George is correct that privacy is really more of an illusion than a truth, there is an interest in the administration in providing privacy to the extent that we can, but making sure that people understand that that is not a guarantee and it's increasingly vulnerable. All of my information, of course, now lives in China because I was part of the OPM hack. And then, as we're developing policies for the Precision Medicine Initiative cohort, we're hoping that those policies and approaches can be adopted by other research programs at NIH and elsewhere. So when we first started this, we put together a working group to Francis's most senior advisory committee, the ACD, the advisory committee to the director, and that working group worked intensively in a really open way over a period of many months last summer, and generated a report and a series of recommendations. And those recommendations included that this cohort should include 1 million or more folks, that it should be longitudinal with continued interactions so that folks are constantly engaged if they want to be constantly engaged, and people can sort of set their preferences for how much they're being touched along the way. It was recommended that we have 2 methods of recruitment. One that is more familiar to us, which is through healthcare provider organizations, so existing health systems, some represented in this room, like Geisinger, Intermountain, Kaiser, et cetera, who have large patient populations that might be interested in participating. That's familiar to us and relatively straightforward. What's less familiar and more complicated is that we really wanted to allow, and the president really wanted to allow, anybody anywhere to raise their hand and say, I want to participate. So my person who I think about sort of in this regard is my mom. So she's got multiple chronic conditions. She's very severely disabled with rheumatoid arthritis. She has a very difficult time getting around. She lives by herself, but in an independent living facility in South St. Paul. She sent me an email message when she was watching the State of the Union, not the last time, but the time before when the president announced this, and typed out a message to me on her iPad with her little stylus and with her little crippled hands and said that she wants to participate. So how do I make that possible, right? That's going to be really difficult. She can't pop in her car, because she doesn't drive, and pop over to a health facility 10 miles away. Something else has to happen to allow her to participate. And similarly, you can imagine any number of people where it will be more difficult to enable them to participate. And then we got to keep expectations grounded. We're not going to like open up and launch the cohort study and have 1 million people immediately. It'll probably take 3 or 4 years to get to that point. So I want to talk a little bit about the timeline that we've been working under. So the president launched the Precision Medicine Initiative in January 2015. Francis put together this advisory group that worked assiduously to put together these awesome recommendations and get broad public input across the board. We delivered that report in September, and it was accepted. We really quickly put out funding opportunities, got applications in December, and made our first awards in February. So that was pretty lightning speed. And the first awards are really to try to figure out how do we do this direct volunteer part? How do we allow anybody anywhere to sign up for this cohort? So we are continuing to put the pieces together. We put together a IRB expressly for this cohort, so it'll be a group of people, a very atypical IRB, frankly, that will be responsible for overseeing this program for its lifetime. So that will be a group of people who know the program, so it's not like they're just walking in the door and reviewing a protocol and first time they've ever seen it. They will get to know this program really, really well. So the other thing that recently happened is that we named our permanent program director, Eric Dishman. He was a member of our working group. He's from Intel. I don't know if you've ever had an opportunity to interact with him or know him. He has enormous energy and creativity and intelligence, which he's going to focus on leading this program, and we are super excited about that, and I am super excited about having him on board. He will start on June 13th, and so now rather than leading the program, I'm really in the phase of overseeing its transition into his capable hands. So over the course of this spring and summer, we're going to be making the awards for the big pieces of this cohort program. And then at some point, and at a date yet to be determined, but it has to be before December because we promised the president that we'll have 79,000 people enrolled by December. Why 79,000? Well, I'm not going to tell you because it's complicated. But why December? And I can tell you why December. Why December is because in January, the president will walk out of the White House for the last time, and I will walk out of Building 1 for the last time, and my boss, Francis Collins, will walk out of our building for the last time. And so we really want to make sure that we have gotten this program off to a very robust and healthy start before I leave, and then that's what I will be doing in January. So let me say just a couple more words about the program. So building a cohort of 1 million volunteers, we want to have participants as our partners all along the way. We want to be able to have electronic health records, and actually this program has been providing a big push for interoperability, for being able to make medical records accessible to individuals in real time, and being able to have, for me being able to get my medical records and then direct them to research without it being a complete and total pain in the butt. We're not there yet. We got a long way to go, but we got a lot of energy behind it. Being able to integrate mobile technologies and environmental sensors into this program, and obviously using genomics and other sorts of laboratory analysis to be able to identify biological markers of health and disease, and then making this data widely available. So those are the sort of the key components, and we have the direct volunteers and the folks who are going to be volunteering through healthcare provider organizations, providing all of this data, all of these biospecimens, and enabling a lot of research to go on using those data and those biospecimens. So this is a big construction project at the present time, with the expectation that we're going to be able to get it underway in the fall and generate a growing, incrementally richer set of data over time. So we get to celebrate our progress so far and the progress that we anticipate at a summit at the White House a couple of months ago. And it was really fascinating watching the president, without any notes, talking with such insight and intelligence and enthusiasm about the precision medicine program. And he talked about the cohort program and precision medicine being the foundation whereby in 10 years we can look back and say that we revolutionized medicine. So that's what we're trying to do. He also has very strong views, which I think you all clearly share by being in this room, to making sure that research participants have access to all of their information. And so this is a quote from that summit, but it is very clear that if we deviate from that expectation, we need to go back and talk to him. So we met with him in July, and he said, I know this is really complicated, but if there's any reason why there's some data that the researchers know about and the participants don't know about, if you anticipate that that's going to happen, you need to come back and see me. And so I want to go back and see him, but not for that particular reason. And so we are working really hard to make this happen. So with that, I am going to say thank you very much. And I'm not sure if I'm going to take questions or, yeah? I'm happy to take a couple questions.
So, is it on?
Yep.
So how do we sign up?
So we are going to do a launch of this program, and in my head, it would be great to do the launch of the direct volunteers and have all the HPOs ready to enroll people at the same time, so we do just this big sign-up time. I'm hoping that's going to be in the early fall, but you'll certainly know about it because we will be singing from the mountaintops.
Great, and I can't wait to be one of the 79,000 to start. I had one question on your slide on recruitment. You had the 1 million volunteers that we were going for in this, and you had a bullet point about it not being statistically representative.
Yes.
What
Yeah.
does that mean?
So you can learn a lot from a large, diverse sample that's not statistically representative. What you can't tell from such a sample is the absolute incidence of something, right? Because you can't extrapolate to the entire population. But you can find lots of stuff that's generalizable. In fact, most of the stuff that we do in biomedical research, except for some epi stuff, is not actually statistically representative. But if you try to be statistically representative, you increase costs. Costs go up really steeply. We had an unfortunate experience in trying to do that with the National Children's Study, which we ultimately ended up declaring a failure and shutting down. And so we try to be clear about that. Also, we really want this study to over-include people who have traditionally been underrepresented in research, because I think that this program really allows a really interesting opportunity to tackle some vexing questions and health disparities that we really haven't had an opportunity to successfully address before. So that's the reason. Thanks for the question.
Okay. It's hard to access precision medicine, and I've been dreaming about it for a long time. So I have ideas to start it immediately in a small psych unit. So I have HPOs and many individuals that want to be part of PMI on July 1st. And we're out here. Now, how do I get my small hospital that's downsizing because of poor corporate healthcare decisions to open an office for precision medicine and wear masks and join the cohort? Or how do I, as an individual, join?
So as an individual, there'll be opportunities to be able to sign up, enroll, become engaged when we launch, which will be later this year. In terms of an individual hospital participating, when we put out an invitation for healthcare provider organizations to apply, and that was put out some time ago and has now closed. So the window for adding additional hospitals right now is closed, but we'll add as we go along, unless you can partner with somebody who we will be selecting. So we'll be announcing who those big healthcare provider organizations are in June. And when we make that announcement, if you can partner with them, that would be an opportunity too.
Thank you.
You're welcome.
Hi, Kathy, thanks. Of course, probably most of us in this room have been waiting a long time for this, and you know that most studies or prospective researchers will say, I don't have the resources for this, I don't have counselors, I don't have a CLIA certified lab, my local IRB will never go for this, FDA has rattled its saber at the Caesars, wham, wham, wham. What do you say to assuage them, other than the president's bully pulpit?
Yeah. Well, to really respond to all those points would take longer than we probably have. I think that issue around an IRB we've solved. So if you want to participate in the Precision Medicine Initiative program, you have to use our IRB, full stop. So we're not going to go through, I mean, can you imagine if we let everybody use their local IRB? We never even get this thing launched. In terms of CLIA, we will collect specimens in a CLIA way in order to make sure that Misha's sample is Misha's sample. But in terms of researchers who are using those samples, not all of them are going to be CLIA certified, right? Somebody's doing basic research, why would they have a CLIA certified lab? And we want those data to be able to go back to people too. That is a monumental policy fight that we are having right now and meeting with the secretary about next week. So we're trying to really make new pathways from a policy perspective that will allow this to go forward. Also working really close with Rob Califf, the commissioner of the FDA, who is, not your mother's, FDA anymore. They're really interested in making this go. So I think we're laying the foundation, and hopefully we'll have it really instantiated before we all walk out the door and turn into frogs.
Will it now become easier to get funding for research that treats aging like a disease? Because I'd heard that the government doesn't normally classify it that way, whether they attempt to do reversal or extending lifespan, that sort of thing. And you probably heard that Harvard Medical School has made very significant progress in the Church lab and the Sinclair lab over here.
So NIH supports a lot of research on the diseases of aging and then healthy aging through, we have an entire institute, the National Institute on Aging. They have had a substantial increase in their funding, most notably because of increased attention and focus on Alzheimer's disease. I would say that we have less attention, but certainly applaud attention on identifying those variables that increase longevity and healthy living.
Yeah. Okay, so funding is available for that sort of thing then?
Yes, there is. Yeah,
Okay,
absolutely.
thank you.
Yeah.
Was there any consideration towards enrolling people who would make their data completely open?
So that's an interesting question, and we could, my expectation is that there's going to be all sorts of networks that we want to enable to grow within this cohort, right? So 1 million people, and there'll be a gazillion networks within it of people linked together by whatever. And so I could imagine that there would be a network within the cohort of people who want to make their data completely available, and we would want to facilitate that. We haven't given a lot of thought because it's just early days, but it'd be fun to talk about. Thank you very much.